Good morning. On behalf of the University of Michigan Injury Prevention Center team and our colleagues at MDHHS, I want to welcome you to the second in a series of discussions related to the opioid epidemic. Today, we're going to focus on equity in pain management and access to SUD treatment. We have 90 minutes and we've built in time for Q&A, so please do ask questions in the Q&A section of the Zoom. We will be saving questions for the end. We are very pleased to have a panel of wonderful experts to share their knowledge with you today. Next slide. Our speakers do not have any disclosures. We have three panelists. The first is Dr. Asabigi. He is the Vice President of the Detroit Recovery Project. He oversees the Certified Community Behavioral Health Clinic and Building Communities and Recovery Program. Prior to his current position, Dr. Asabigi worked for the City of Detroit Health Department, and he has held executive-level positions in the private as well as nonprofit health sectors for the past 30 years. Dr. Mitchell is the executive director of CLASS. She focuses her efforts on 4 objectives: eliminating health disparities, building healthy and safe community environments, and empowering people to make informed health choices, and expanding quality care in both clinical and community settings. Dr. Mitchell first served the organization as a board member for several years before becoming the executive director in 2017. And last but not least, Ms. Stroh-Steiner has had multiple roles at MDHHS over the past 7 years. Currently, she is the lead drug surveillance epidemiologist at MDHHS. She co-authored the 2020 and 2022 Substance Use Vulnerability Index report and created this online tool that she's going to explore with you. She is also the co-author of the 2018 Overdose Health Equity Report. Next slide. Before we get started, we have 2 quick questions that we're going to put in a poll. Taylor, if you can pull that up. And here are the results. And we can see that some people are very confident and have a lot of knowledge in this space, and some of us do not. So hopefully this seminar will get everybody feeling confident, if not very confident, in their ability to enhance and improve equity in the care of patients with pain and substance use disorders. And here's question number 2. This is an open answer question. What are some of the barriers to providing equitable care in your practice or your work? While you think about that, let me keep on going with our introductory slides. Jill, can you give me the next slide? So as we spoke, as we explored in our first seminar, and as we want to remind you today, providers can make a difference in this space. We can bend the curve, and many patients and individuals in our communities are doing critical harm reduction work. In addition, as clinicians and providers and community members and folks in public health, we can engage in prevention and help those with opiate use disorder obtain treatment. Next slide. It is critical that we take a holistic approach to the opioid epidemic. As providers, we need to be patient-centered. Next slide. There is a lot of work to do as we face the opioid epidemic. Today, we're going to focus on one aspect, and that is equity. There are lots of other really important topics that we'll be addressing in the future. So please tell us if there are specific ones that you want us to explore in future seminars. Next slide. This is our agenda for today. We're going to cover a lot of ground. I also want to remind everybody that in order to receive CME for this event, you must complete the evaluation after the session. It will be emailed to you in the next week, and you can claim up to 1.5 hours of AMA PRA Category 1 credit. Next slide. I am thrilled to introduce Dr. Karla Mitchell. She is going to ground our conversation for this session. She's going to speak about health disparities and equity in healthcare, and she's going to share some data regarding how we're doing in Michigan.
Thank you so much, Eve. Jill, can you advance to the next slide, please? Good morning, everybody. I am very happy to be a part of this webinar today. And one of the things that is very important as we start this discussion is to level set our understanding on why a discussion in equity is important, and to also understand that a discussion in equity generally cannot happen without an understanding of disparity. And so I want to orient your understanding to the resources and the statistics that are out there regarding what's happening in the state of health of Michigan. So what we have here is a report that has been published by the Commonwealth Fund on advancing racial equity in U.S. healthcare. This report evaluates disparities in health and healthcare across racial and ethnic groups, both within states and in between U.S. states. And the data that was collected has ranked the state of Michigan relatively low as compared to other states. The little red arrow indicates where Michigan falls on this scale. And ultimately, what it does is it evaluates 25 indicators of health system performance, specifically focusing on health outcomes, access to healthcare, and quality and use of healthcare services for Black, white, Hispanic, and American Indian and Alaskan Natives, and Asian Americans, as well as Native Americans and Pacific Islanders. There is a resource, the link to look deeper into that report is there. I encourage you to do that so that you have some good understanding. And in addition to that, you can find lots of articles that have been written about the health disparities that are stark for Black residents in the state of Michigan. Next slide, please, Jill. In addition to understanding the state of disparity in Michigan, there is another study that has been published with regard to the cycle of racism and bias. People often ask themselves, why do disparities exist? And that conversation can't take place without an understanding of the structural racism and bias that exists in the healthcare system. There was a poll done of health workers, about 3,000 health workers across the nation. 47% of those healthcare workers reported witnessing patients face racism or discrimination based on their race or ethnicity. Of that 47% of healthcare workers who reported witnessing patients face racism, 74% of those reported an occurrence within the last 3 years. So a lot of times these uncomfortable conversations about racism and bias come with that doesn't happen anymore. This is a recent study of healthcare workers that shows that this is very alive and present in the healthcare system. And I like to have this conversation in a way that does not shame or guilt people for the way that they have been socialized. And so it's important for us to understand that biases develop across the course of life as a result of socialization and exposure to certain messages within a culture. So nobody sets up or wakes up in the morning with the intent to be biased, but it is a very real thing that we all have to face on a daily basis. This slide essentially shows us the continuous cycle of racism and bias. And it also depicts that racism and bias are aspects of life that are actually affected by its structural inequities that produce inequitable outcomes, that reinforce the stereotypes that individual or some groups of people cannot see if they are not attuned to it. Next slide, please, Jill. In addition to this cycle of racism and bias, I like to introduce people to the social ecological model of health that teaches us that health is affected by the interaction between not only individuals, but our groups, our institutions, our communities, and our policies. And it helps us to understand that implicit bias happens in the situations where we are not cognizant of all these influences. Some of the questions that I ask people to consider for reflection in your everyday life include whether or not you are prone to or attracted to servicing certain populations or excluding yourself from servicing populations, or when you're evaluating where you're looking for an apartment or what types of institutional settings you're going to work in, do you consider the populations surrounding those settings, and why? What are your reasons? Another question that you might ask yourself is that, do you automatically exclude certain neighborhoods or places you might live? And do you know why you do these types of things? And if you look closely at this slide and the resources that are shared, there's actually a socio-ecological model for chronic pain that helps you to understand those elements of each one of these areas so that you can consider to continue to do a deeper dive into how the cycle of racism and bias actually influences the way that you deliver care. Next slide, please. Here, I'm sharing with you an example of what we're talking about. This figure shows a conceptual model and really demonstrates the influence of implicit bias on a hypertension and how it may affect how the patient-clinician relationship is during the process of treatment. Also shown in this figure is the possibility of implicit bias by affecting the treatment through its effects on the interpersonal communication with the patient. Next slide, please. Implicit bias is something that has been studied for quite some time. If you're not familiar with implicit bias, Harvard University did a study, a project called Project Implicit, and they offer a actual free implicit association test. It's called the IAT. I encourage you to explore the link and take the test. You might be surprised at its findings. It's important to understand that implicit bias is distinct from explicit bias. Explicit bias requires that a person is aware of his evaluation of a particular group or believes that evaluation is correct and has the time and the motivation to act on it in a current situation. Implicit bias, however, is a far subtler form of discriminatory action outside of your conscious awareness. It can occur at multiple levels in the form of stereotypes, microaggression, or just general implicit bias. And I encourage practitioners who are not familiar with the concept of implicit bias to explore it more. Next slide, please, Jill. Here is some additional breakdowns of information from the Commonwealth Fund. It also talks a lot about health system performance by race and ethnicity. Compared to other states in the Great Lakes region, Michigan has more severe racial and ethnic health disparities. Black people experience the lowest health system performance in the state, scoring in the 19th percentile. If you take a closer look at this slide, you can see the arrows indicating where Michigan ranked in this assessment. We understand this to mean that there are factors contributing to health disparities that include deep racial and ethnic differences that include poverty rates that are higher than average, levels of pollution and crime are elevated, and green spaces are few in a lot of the communities where these disparities exist. There is also a lack of affordable quality healthcare options, and it can make it difficult to get timely treatment for a lot of people. This is a barrier that we happen to know that a lot of people of color disproportionately face. Next slide, please. A deeper dive into the Commonwealth Fund report also shows us that Michigan ranks 29 of 39 states where this calculation is possible. It's asking us the question of how well does the health system in Michigan work for people from different racial and ethnic groups. Michigan ranks 12th of 47 states where a calculation was possible, indicating that health system performance for Hispanic people in the state was better than average compared to other states. Next slide, please. All this to say that the disparities we see in state and national data are felt at the bedside, and they are felt by patients who are in pain. Next slide, please. As you can see, the disparities conversation spans across all areas, particularly in pain management. It is important to consider that chronic pain is a huge issue in our country, and our implicit biases enter the clinical space when we enter the clinical space. Next slide, please. There's a ton of research that shows that no matter what pain type you are examining, there are disparities. long bone fractures, appendicitis, post-operative pain, cancer pain, low back pain. Black patients receive less analgesics for fractures in emergency rooms than white patients. 57% to 74%. When facing metastatic or recurrent cancer, BIPOC patients receive inadequate pain management medications compared to white patients. Black women have been historically underdiagnosed and treated for endometriosis due to persistent stereotypes that the condition is more common in white women. Black individuals experience greater pain sensitivity and burdens, including functional limitations in comparison to white patients for many chronic non-cancer pain conditions such as arthritis and migraines. Hispanic Americans with chronic pain face more stigma, greater cost barriers due to lack of insurance, and less access to pain treatment compared to other individuals living with chronic pain. Indigenous people in rural and tribal regions feel underserved by the healthcare system. They lack access to pain management providers and report that providers ignore, untreat, or overlook their pain. In addition to undertreatment, racial discrimination can lead to chronic stress and increase immune-mediated inflammatory responses in patients, all of which heighten these individuals' risks for developing other chronic conditions. Next slide, please. Why do we have disparities in pain management? We forget that race is a social construct, and the myths that were perpetuated to justify slavery do live on. We have false beliefs about how pain is experienced and the biology of individuals. Providers with more false beliefs rate Black individuals as experiencing less pain. Importantly, those with fewer false beliefs do not differentiate. This tells us that education and awareness can make a difference here. Emory University has published a study or an infographic on race and pain assessment. Next slide, please. These graphics and the message of these slides can be replicated really in any setting. Next slide, please. We have spoken about the challenges with pain management. With regards to SUD treatment, access is also a big challenge for all individuals in our country. Next slide, please. The disparities we see at a health system level are seen in access to SUD and MOUD management. This analysis examines Medicaid claims data from 2020 to understand clinically identified rates of SUD, as well as treatment patterns across SUD services. How treatment rates vary across groups of Medicaid enrollees in states and spending among Medicaid enrollees aged 12 to 64 who have a diagnosed substance use disorder. Next slide, please. Unequal access to SUD and OUD treatment is likely one of the reasons that overdoses have risen over the past few years. This is postulated to contribute to the rise in overdose deaths among Black men. This trend is national, and we see similar statistics in Michigan. Next slide, please. So how do we go from health disparities to health equity? Do we understand what equity is and the distinction between equality, equity, and justice? Next slide, please. Oftentimes, the concept of equity is confused with equality. This graphic is used to help distinguish the difference between these two terms. Equality is about evenly distributing tools and resources. Equity is custom tools that identify and address inequality. And justice itself is about fixing the system and the structure to offer access to both relevant, competent, and appropriate tools, resources, and opportunities. Next slide, please. So when we think about health equity and access to healthcare, we must understand that it is a societal issue. Much discussion around the ways in which disparate populations interact with healthcare systems in general is centered around social determinants of health. Great research has gone into establishing this framework for how we quantify and approach what public health believes influences health outcomes. But I'm excited to share with you some of the findings from a Michigan Health Endowment Fund study that we performed, the class agency performed with SHARE over the past year, and that will come later in our presentation. Next slide, please. When a society's principles and policies work to improve these social determinants of health, to promote justice and equity for everyone, health is created at the level of the individual, the community, the environment, and the society at large. When any combination of these conditions is lacking, the engine that powers health can break down, resulting in significant health inequities and disparities in health outcomes. Those significant disparities include higher incidence and or prevalence of disease, including early onset and more aggressive progression of disease, premature or excessive mortality from specific health conditions, greater global burden of disease, such as disability-adjusted life years as measured by population health metrics, poorer health behaviors and clinical outcomes related to the aforementioned, and worse outcomes on validated self-reported measures that reflect daily functioning or symptoms from specific conditions. Next we have Ms. Gabrielle Stroh-Steiner, who is going to discuss efforts in Michigan to use the social ecological model approach to understanding the effects of the opioid epidemic and its effects on our citizens.
Thank you so much, Dr. Mitchell. And thank you for that wonderful background and grounding discussion on health equity. So as Dr. Mitchell mentioned, I'm Gabrielle Stroh-Steiner. I am an epidemiologist at MDHHS, and I'll be continuing our conversation today by talking about some of our efforts at the state to incorporate a social determinants of health lens into our data projects related to substance use. So next slide. So just a brief outline of what we'll be walking through. We'll be discussing the social determinants of health and their relationship with substance use, and then discussing a data project that we have been working on at the state, the Michigan Substance Use Vulnerability Index, or MySUD, where we've really been trying to bring a health equity lens into our data efforts. And then we'll talk through a couple interesting data examples from the MySUD and discuss what they can tell us. So next slide. So I wanted to start off by talking about the social determinants of health and defining what they are. Dr. Mitchell gave us a really wonderful background on health equity. The social determinants of health are another concept within the sphere of health equity that helps us understand health disparities and why they occur. So this is a definition that comes from Healthy People 2030 that defines the social determinants of health as the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So considering a social determinants of health perspective moves away from just a very individual focused view of health conditions. It moves away from putting the blame on individuals for health conditions they may experience and zooms out into a more holistic view of understanding structural factors that impact the health decisions individuals are able to make and the health outcomes and quality of life they're able to attain. Next slide. And so this slide are just some graphics that I like to include when I talk about the social determinants of health. On the left, we have a figure from Healthy People 2030 that shows these different categories of structural factors that fall into the social determinants of health. So we see healthcare access and quality, neighborhood and built environment, social and community context, economic stability, and education access and quality is all being structural factors in our lives that significantly influence the health outcomes we are able to achieve. On the right, we see a graph on the social ecological model of substance use and overdose prevention. And so Dr. Mitchell already brought some figures on this in the discussion. So this is kind of just a review, but this is from the Minnesota Department of Health. They have a lot of really wonderful resources on health equity. But again, just emphasizing that there are societal structures that influence our communities that then go on to influence our interpersonal relationships that influence our quality of life as individuals. Next slide. So this figure is kind of diving in a bit more to that social ecological model and providing some specific examples within each of these spheres for how social determinants of health may influence our health outcomes, and specifically with relation to overdose and substance use. So in the policy circle, we see factors such as affordable health insurance, livable income, funding for culturally specific prevention programs, policies that focus on adverse childhood experiences, historical trauma, structural racism. These are all large structural factors that filter down and affect us at the individual level. And they do that by affecting the communities we live in, whether we experience safe neighborhoods, we have access to food and transportation, culturally specific healthcare and public health education. And all of these factors then go on to impact our families and our interpersonal relationships, which then influence our individual experience of our mental, physical, and chemical health. Next slide. So why are we talking about all of this? Why are we talking about the social determinants of health and health equity in this discussion? So this graph is taken from our public-facing data dashboard, and it shows the astronomical increase in the overdose death rate in the United States and in Michigan over the past 2.5 decades. And I doubt this comes as a surprise to anyone on this call that overdoses are extremely high in our state and in our country right now compared to the historical rates. And even though we're starting to see that curve bend and see decreases in Michigan in the last 2 years, they still remain extremely elevated. And we're not seeing that decrease equally across all groups. We're seeing the overdose rate begin to decrease in the white population, which is driving the overall trend, but we're seeing continued increases among the Black population in Michigan. So we're not seeing equitable change in our state. And so this is where the social determinants of health and a health equity framework really matter. We need to think about these larger structural factors that intersect with individuals' experience of their substance use disorder. And we need to address these structural things that create gaps and barriers for different groups of people in order to affect equitable change in our state in the overdose space. Next slide. So with that in mind, I'm going to transition into talking about a data tool our team has created called the Michigan Substance Use Vulnerability Index. And so as our team has worked in this space, providing data to program and policy makers, we noticed over the years a gap in the data that was being used for decision-making. Historically, we've seen overdose death data driving a lot of decision-making in the program and policy space. But we know that there is so much more that influences individuals' experience of their substance use disorder. And there are many different data points and characteristics of communities that are influencing substance use disorder and overdose deaths. And so our team really wanted to create a more holistic data tool with a health equity approach that would help programs and policymakers and individuals working in this space to better understand the substance use landscape in our state and to understand social determinants of health that may be driving the trends and disparities we see in our state. Next slide. So how does this tool function? I'm not going to get too into the weeds or do like a statistical lesson today. We have a lot of documentation online if you're interested in digging in more. But at a high level, this tool is a composite index score. And what that means is that it's taking different data indicators that are related to your outcome of interest, and it's standardizing them so they're on the same scale and adding them together to create a single score. So for the SUD, the Substance Use Vulnerability Index, our score is influenced by these three different larger categories. So we have substance use burden, substance use resources, and social vulnerability equally feeding into the SUD. And so it was important to us that each of those three things was equally weighted and equally considered as we make decisions in the program and policy space. Next slide. And so just a little bit more on the social vulnerability pillar. This is based on a framework and a tool created by the CDC, the Social Vulnerability Index. And this tool is really looking at data points related to those social determinants of health and how how those fuel health outcomes and substance use disorder outcomes that we see in communities. So this tool includes data points related to socioeconomic status, household composition, racial and ethnic minority status, housing type and transportation, and healthcare connectedness. So we see all of those community characteristics as influencing health outcomes in the substance use disorder space. And they need to be equally considered as we think about treating individuals and creating effective programs. Next slide. So if you're interested in seeing more data from the MySUBI, I'm just going to give like some little data snapshots, but if you're interested in digging in more, all of the materials are available publicly. We have a data page on our dashboard that gives an overview of MySUBI results at the county and zip code level, as well as county profiles, where you can understand the data points in your county in relation to other counties. And then a data page that allows you to compare data points. So you can look at where overdoses are high in your community, but treatment or harm reduction access may be low. Next slide. And then something that we just like to say when we talk about this tool is that it's not perfect. We do think it is a more holistic picture of what is happening in our state and the data elements we need to consider as we plan programs and policy and allocate funding, but it still has limitations and gaps. And so we always want to emphasize that considering local context and knowledge and relationships are key, and especially hearing from individuals with diverse backgrounds and with lived experience, that is really essential to be able to make effective policies and programs. And so even though the MySUBI is not perfect, we know there are things that we're not capturing that should be considered as we're making decisions in this space. Next slide. So I want to transition into talking about some data findings from the MySUBI that can help us understand why it's really important to approach this topic and approach data analysis with a health equity informed lens. So in this first case study, we're looking at two different counties in Michigan, Lake versus Grand Traverse counties, and we're pulling out some data points from the SUBI. So in the table on the left, we can see that over the past 5 years, Lake and Grand Traverse counties have had very similar overdose fatality rates, and both of which are lower than the Michigan county average. So if we were just looking at overdose data for these two counties, we might think, the two counties are very similar and they're doing better than the county average. But that would be an incomplete picture of what is going on for these counties. And we need to dive into the data more to truly understand the landscape in them. So when we look at the social vulnerability index and those social vulnerability related data points, we see a different picture emerge. And so on the right here, you can see a graph. Blue is Lake County, which is ranked as having more social vulnerability compared to Grand Traverse and the My County average on different social characteristics data points that are included in the SUBI. And so we see that Lake County has substantially more individuals that are living below the 150% poverty line than Grand Traverse County. And we see more individuals that are unemployed with high housing cost burden, no high school diploma, identifying as not white, living in mobile homes without internet. So this is a very different picture that emerges than if we were to just look at the overdose fatality rates in the two counties. And I show this example to really emphasize that we need to understand the structural and social characteristics of our state and communities as we work with patients and as we create programs. They need to be appropriately tailored and to understand individual and community and structural barriers that individuals with substance use disorder face as they are trying to navigate their health decisions. Next slide. The next example that I wanted to show is in Washtenaw County. This is where I live, and I know there's a lot of work to be done in this county, so I like to bring this example to the table. On the left, we see a map of the substance use vulnerability index rankings among counties in Michigan. And we see that Washtenaw County is in the least vulnerable quartile in the SUD. So if we looked at this graph on the left, we might think Washtenaw is doing really well overall and may not need more support or resources. But looking at things at just the county level can mask what is actually going on in specific communities and barriers and gaps that may exist for specific individuals within that county. So this graph on the right, digging in a little bit more, is a metric that called the Gini Index. It measures income inequality in counties. And so we see that Michigan ranks 5th out of all counties in Michigan and is in the top 15th percentile of counties in the entire United States in terms of income inequality. So even though the SUD score for Washtenaw is in the least vulnerable quadrant, we see that there's significant inequality in Washtenaw County. Next slide. And again, digging into this a little bit more, these are maps of zip codes within Washtenaw County, looking at the substance use burden score, resources score, and social vulnerability score from the Substance Use Vulnerability Index. And so we see that things aren't uniform across zip codes within our county. On the left, we see that the overdose substance use burden is higher in those zip codes on the right side of the map. And those are closer to the Ypsilanti area. And on the map on the right, we see that those areas also experience more social vulnerability. And so as compared to some of the zip codes surrounding the Ann Arbor area in the middle. So we see that things are not equal in our county, and we need to consider those things as we think about who needs more tailored programming and what patients may experience more barriers as they navigate their substance use disorder. Next slide. And then finally, this is just looking at Washtenaw County again, pulling out those 2 zip codes that had the highest burden and social vulnerability and looking at some social characteristics compared to less vulnerable zip codes in Washtenaw County. And we see again that the blue zip codes have higher individuals in poverty and with high housing costs and more individuals that identify as not white, non-Hispanic. And so again, just really emphasizing that we need to be thinking of a more holistic picture as we treat patients and as we tailor our programs. We need to think about if our programs are culturally competent. We can't use a one-size-fits-all model and expect to have equitable and equal impact in the overdose space. We need to be more intentional in order to affect equitable change in our state. Next slide. So just kind of wrapping that up with our conversation so far and the data points we've seen here. How can we achieve a more equitable treatment and recovery landscape in Michigan for those living with SUD? First off, we need to acknowledge these structural factors that filter down and impact individual health experiences and quality of life. And we need to use data to understand the impact of these structural factors and what disparities exist in our state. While looking at data, we also need to acknowledge the limitations of data and populations that we may not be able to measure that also are experiencing higher vulnerability. And we need to always seek to understand local and cultural context and to elevate diverse voices and those with lived experience as we seek to implement effective and equitable programs in patient care. Next slide. So I am now going to turn things over to Dr. Asabigi, who will continue the conversation by sharing about the current state of resources for individuals with SUD seeking treatment and how providers can help patients access the care that they want and need. Thank you.
Thank you, Gabrielle, and thank you, participants, for joining us today. The 2 presenters, Gabrielle and Dr. Mitchell, have provided a lot of information about health disparities when it comes to SUD, substance use disorders. I'm Dr. Kanzoni Asabigi. I'm Vice President at Detroit Recovery Project, but I also worked for the Detroit Health Department for almost 2 decades, overseeing substance use disorders for the programs for the city of Detroit. So my focus has been in getting people into treatment. And I just wanted to say that as a trained family doctor, I had no idea when I first started practicing about the resources available. All I told my patients was, you need to quit drinking or stop smoking or don't use drugs. And that wasn't enough. So until I got to the Detroit Health Department and got immersed into substance use disorder and mental health services, that I realized that there's a lot more that providers can do to help individuals suffering from SUD. So in 2012, the state of Michigan revamped the way that funds were provided to municipalities and regions for providing substance use disorder services and mental health. So counties were divided into what regions called PIHPs, prepaid inpatient health plans, PIHPs. And as you can see in the on the slide here, there are 3 individual counties that are PIHPs. That's Wayne, Oakland, and Macomb. The rest are 2 or more counties that represent one PIHP. And these PIHPs primarily fund services for vulnerable populations, Medicaid expansion or Health in Michigan, individuals that are underinsured, and individuals that have no insurance. And those are funds funded through what we call block grant. So these entities receive funding from the state and federal government to provide SUD services, mental health services, and intellectual and developmental needs, disabilities. So it is very important that providers know about these PIHPs in their regions. It is very important to get their telephone numbers and know how they work. These PIHPs also have a network of providers that provide these services. So they contract with a network of providers in that region. And if they don't have a particular specialty in that region, they provide those services through contracts in the various areas. So the entire state is covered with these PIHPs. One caveat also to note for mental health is that for vulnerable populations, especially Medicaid, some parts of those funds go to the Medicaid HMOs. So for mental health, those suffering from mild to moderate disorders are funded through the HMOs, and those with severe and persistent mental illness through these PIHPs. I'm not sure how that happened, but this is where we are. Next slide, please. Yeah, so the PIHPs primarily fund the public sector. That's where majority of individuals needing SUD and mental health services get the care that they need. Then we also have the private sector. The private sector, individuals with insurance, and sometimes individuals without insurance, but they have the means to pay. And so they make their own choices. But those who have private insurance, it depends on the type of insurance that they have and the limitations that come with the coverage. Hopefully one day we'll have parity. We should have it by now, whereby there's no distinction between physical health and mental health, and no limitations. If you need the care, you get the care. So Medicare pays for some services, but not all services. In private insurance, there might be some limitations as to the number of visits per year that would vary, and deductibles and co-pays, and how many times that you can see a particular specialist. Some individuals are underinsured because of the coverage, and those that are underinsured can get services through the PIHP if they qualify based on the annual salary that they make and their family size. They also may qualify for what we call a sliding fee scale. So they will be charged based on how much they make a year and the family size, so that they can access those services. Next slide, please. Yes, so the type of SUD services that are available through these PIHPs include residential services, where individuals are housed in that entity and then they undergo intense counseling for a given period of time. So some may be there for 90 days or more, depending on their needs, and then they are discharged to an outpatient setting. Outpatient substance use treatment would also include telehealth, which is really fantastic. And this also took off after the COVID epidemic. And so we're able to reach people at their home, or if they're not able to come to the clinic. They can also come to the clinic and receive services, and also participate in recovery support groups. There's also medication for opioid use disorders. So methadone, which is a long-acting opioid agonist, has been around for a long time. And these are, prescribed by physicians operating in the opioid treatment programs. We also have buprenorphine, which has been, has been around for some time now, and Vivitrol, now naltrexone. So these here, although we're not going to talk about, the treatment mechanisms, I just want you to know that these are available, and there are various programs within the PIHP and in your area. Get to know them, establish relationship with them, call them, and refer individuals to for treatment. We also have intensive outpatient services, or what we call IOP, and also for IOPD with domicile. So some people can get intensive services, come 3 to 5 times a week for counseling on an outpatient basis, or they may be housed, that's what we call IOPD, in a particular entity where they receive intensive treatment and counseling, together with co-occurring disorders. A lot of people suffering from SUD also have mental health disorders. Then we also have subacute detox. This is not a medical detox, okay? So you wouldn't have people who are suffering withdrawal symptoms in this type of setting. So these are monitored, individuals are monitored by a nurse or a physician, and making sure that, they do not undergo withdrawal symptoms, and then transition to an OTP if that is necessary, or other outpatient services. There are also women-specific programs for individuals, for women with children who suffer from SUD. Now, women-specific programs have now been extended to men also, because some men have custody of their kids if they suffer from SUD or have a history of SUD. So this was really good news that the state and the federal government allowed men to also participate in these programs. So the gist of the women-specific specialty services is to make sure that, one, the parent receives the service and that they need, maintain family unity, and also provide prevention services to the kids. because they are at increased risk of getting involved with drugs. The last service that I want to talk about is recovery housing. Now, this is new. So in the past, a lot of people go into services, they're done with treatment, but they have no place to go. And so when they're discharged, they go back onto the street, and then they end back into treatment or sometimes in jail. So having realized this, the federal government and the state of Michigan developed procedures and mechanisms, to fund these recovery housing where individuals after treatment can go into recovery housing for at least 3 to 4 months, and those can be extended whilst they look for temporary or permanent housing or transitional housing. Next slide, please. So Michigan is striving for a recovery-oriented systems of care. Having realized that a lot of people go into treatment more than once, and the majority go multiple times before they sustain their recovery, this strives to provide a continuum of care. This is a chronic disease. It's just like diabetes. You have to maintain recovery so the individual does not relapse. Making sure that they have a sponsor or a recovery coach, making sure that they are constantly thriving, making sure that they attend to their medical needs, making sure that there's communication between physical health, mental health, substance use disorder providers, and other social entities whereby people can get housing, they can get food stamps, they can get services that would improve their quality of life. This is person and family centered, which is really important. Person and family centers, very, very important. It's individualized, culturally competent providers involved in providing services. Next slide, please. So this last slide, I wanted to emphasize the need to advocate for your patient. You're a provider or a physician, you need to advocate for a patient. The system that I described is complicated, even for those of us who are educated and have been in this, they're working with this system for some time now. So you need to just advocate for your patient, identify their needs, make a warm handover to the other provider, giving a patient suffering from SUD a number to just call or an address to go to, in my opinion, is not sufficient. You have to be intentional, call, make an appointment, encourage them to go. Know what they need, meet them where they are. They may not be ready fully, but continue to engage with them. Of the resources. Beware of how, for example, somebody that doesn't have insurance, you can easily apply. Now they don't have to go to see their worker. You can apply through My Bridges at the state electronically. And based on my experience, over 90% of them qualify for Medicaid or health in Michigan. Know where there is housing, transitional housing, where they will go. Will they have a meal? These are some of the things that, we don't ordinarily think about because we just take it for granted that, we have a place to go to lay our head. We have a meal, morning, afternoon, and evening, but that's not so for a lot of individuals suffering from SUD. They may have family, but they may also have broken a lot of relationships, and trying to get them back is not always easy. find out what's going on in their lives. Do they have family support? Sometimes yes, but most often no. Are they employed? Are they ready for employment? Are they experiencing domestic abuse or sex trafficking? There are various resources in the community where we can provide these services and link them to these services. So providers don't necessarily have to provide all the services that an individual needs. If you have it, that's okay, but I doubt that most providers will have that. But identifying the right entity or the right partner to refer your patient or client to is key. Beware of the social services resources. Individuals suffering from SUD are sometimes involved in the legal system. So they may have multiple felonies or sometimes have current legal issues. In our area, for example, we have legal aid. Know their number, call them, and sometimes open an office in your facility, one day a week or any other time that they can provide. Is very important and very, very, very helpful. They may not be open to talking. Loss of regulation punish people suffering from SUD, for example, people with children. So they do not, especially parents with children, do not want to say a whole lot for fear of losing their kids. Lastly, it's very important to build trust. It takes time before individuals suffering from SUD will open up. If they trust you, they'll tell you everything. If they don't trust you, it would take some time for you to gain their trust and for them to open up and tell you what's actually going on with them. That's when you can provide those services or link them to the right service. Lastly, every patient and every client is unique. Be prepared for that. They have unique circumstances, but they also come with strengths. They come with strengths. So let's not focus only on the weaknesses of individuals suffering from SUD. We need to focus also on the strength that they bring to the table so that we can help them sustain their recovery. Next slide, please. So at this point, I'd like to reintroduce Dr. Karla Mitchell, who will now discuss some of the work she has done to explore the underlying cause of behavioral and SUD treatment disparities in Detroit. She will also share insights and tools for providers and organizations to improve equity in this area.
Thank you so much, Dr. Asabigi, for such an accurate display and conveyance of what's happening in the SUD provider network here in Michigan. What you see now on your screen is the results of a study that was conducted by the Michigan Health Endowment Fund and the Michigan Public Health Institute to examine racial disparities in behavioral health. I share this information as the precedent to some discovery project work that Class Agency and SHARE worked on for the past 2 years. What this information illustrates is that there are significant disparities for African Americans engaging in treatment and receiving follow-up for behavioral health and SUD care compared to whites in Wayne County. I happen to know that this study was conducted for 4 counties in the state of Michigan, and those resources to connect with those outcomes have been provided as part of this presentation and the resources associated with it. Findings of this study results indicate a large disparity between white and African Americans in follow-up after ED visit for a SUD crisis. Similarly, African Americans showed a lower follow-up rate than white persons after hospitalization for behavioral health episodes. And given the wide disparities in follow-up after SUD emergency room visits for African Americans, collaborative partnerships were created by the Michigan Health Endowment Fund to investigate why African Americans were upwards of 30% less likely to return for follow-up care. Next slide, please. There were racial and ethnic disparities in quality of care in all counties in all years for most measures. There were differences in the extent of the disparity depending on the measure, county, and year. County level rates for white populations are consistently higher than the statewide average. And despite considerable racial, ethnic, and geographic disparities, Michigan statewide rates consistently exceed national benchmarks overall, demonstrating a high level of quality across the Medicaid program for all measures. What you're looking at in this this waterfall chart is a comparative analysis of follow-up after alcohol and drug use, abuse dependence, follow-up after a mental illness, and a follow-up after hospitalization. And what this waterfall chart actually illustrates is the determining factor of if there were equitable services being delivered between Black and white patients in Wayne County, all of these bars would actually be at 0. Next slide, please. As a result of those findings, the Michigan Health Endowment Fund partnered with Class and Share Inc. to conduct a study. We did a county-wide study that revealed some very interesting outcomes as a result of people answering questions why they did not return for follow-up care. We were able to get a survey completed of greater than 5,000 respondents. And some of the highlights from that study are shown here. Ultimately, what we found was that hospital staff would give the name of only one treatment service provider, and that had the largest negative impact in terms of why people would not return for follow-up care. And it indicated to us that there were a lot of reciprocal relationships that existed among providers and hospitals that did not necessarily consider the needs of the people who were requiring services. And this tells us that a lot of times well-intentioned healthcare systems will create a workflow that they believe is awesome without asking consumers or users of healthcare if it actually works for them, because we know that oftentimes transportation is a barrier to access. And so these reciprocal relationships that exist between hospitals and treatment providers, or giving people only one treatment service provider, had a lot to do with why people would not return for follow-up care after a crisis. One of the solutions that Class agency devised to address this was to create a directory by zip code of community-based mental or behavioral health providers that could be shared in EDs and with consumers, so they would have their choice of where they would go for follow-up. Next slide, please. The slide that you're now looking at is a snapshot, a one-page tool that we use as a talking point to really describe the bulk of that study, what our discovery process method was, and what African Americans said their barriers were. And again, in terms of system barriers, they talked a lot about not having enough choice in terms of what was convenient for them and where they could access their follow-up care. And then also, what Dr. Asabigi described in his presentation as clinicians needing to do a warm handoff in that process. So they described there's no accessibility being a barrier to returning for follow-up care as it stands. And in current practice and some of the outreach work that we do, people who have experienced a crisis episode do not have the patience to sit and wait on hold for 40 minutes to have a biopsychosocial done so that they can get access to care. And so in those regards, from reception to admission to treatment, understanding how to navigate insurance, those were reported as some accessibility barriers by the people that we surveyed. And then also stigma still plays a really big part in people accessing care. Some of the institutional barriers that were called out in our discovery project was a lack of respect. Administrative staff treating individuals negatively due to substance use or mental health crises. And then the shorter treatment terms, having only 28 days for treatment compared to a previous 90-day standard. That's a policy issue that was outlined in our discovery project. Next slide, please. Some of the actions that we thought would be useful for addressing some of the barriers that were described by the people that we surveyed was to create a user-friendly database that lists all of the different treatment options by zip code, and to standardize a referral process that includes multiple options for treatment. We talked about a system-wide training on first responders and administrative team members that help them to understand what culturally responsive communication looks like. Dr. Asabigi described some of that in his presentation as, having patience or not having biases towards people who experience issues with mental health, unaddressed mental health issues or with substance use disorder issues. And then we also recommended policy changes that require all treatment centers to have community benefit policies. A lot has changed in the healthcare landscape in Wayne County, specifically Detroit, where community benefit would require institutions to work with community-based organizations to bridge gaps between consumers and practitioners. And the goal of a community benefit policy, obviously, is to increase the collaboration between facilities and other community-based organizations. We don't see a lot of that right now. And so that was another recommendation that came out of our report. Next slide, please. We believe that providers can absolutely make a difference. And one of the ways to do that is to humanize the healthcare experience by prioritizing relationship-based trust and pain-affirming care, listening to the patient, as Dr. Asabigi said, believing and addressing their report of pain. Also taking a personal responsibility to understand how implicit biases and the lack of cultural humility and cultural competency impedes positive health outcomes. We ask that practitioners and providers continue to consider how to develop and understand tactics that help to mitigate your own personal implicit biases and that exists within organizations and systems, and to reduce your unconscious and implicit bias that helps to feed stigma. Next slide, please. It is also a great idea to partner with community-based organizations. Class Agency runs a program called Bridging the Gap that increases access and linkage to care by doing warm handoff processes. We get a lot of referrals from emergency rooms to do that so that we can increase the outcome of follow-up care or the instances of follow-up care. We also think that providers can make a difference by providing education to patients and communities and policymakers on behalf of people who utilize healthcare. Value and integrate peer support workforce and value their lived experience. There has been a lot of discussions at the state level about the value of peer support workforce, which helps to really mitigate stigma. It helps to bridge that gap in communication between providers, practitioners, and consumers, and also become knowledgeable. Another way that a provider can make a difference is by becoming knowledgeable and distributing opioid education and Narcan or naloxone resources to at-risk patients and educating them about all the harm reduction options that are available to them in the state. Next slide, please. And here is a slide that really illustrates more or reiterates how communities and organizations can make a difference. As a practitioner who not only advocates for change at the systems level, I am also a practitioner who actualizes change and equity in the way that I engage consumers of care, and I acknowledge their harms and experiences. And I try to model passion and deliver pain-affirming care. There are some resources that follow on the next slide. Next slide, please. Here are some incredible resources that have been developed by organizations that are really a repository of various resources that address stigma and implicit bias. The National Institute of Health just concluded a process on advancing health equity and pain management, which is an exceptional resource. I encourage those of you who are in the webinar today to dig a little bit deeper if you just pick one and learn more about what you can do as a provider to make a difference. Next slide, please. This slide is a resource culmination of the Michigan Health Endowment Fund Discovery Project that Class Share and the Detroit Way Integrative Network did over the past 2 years. It also includes the Behavioral Health Disparities Report across the state that was conducted by the Michigan Public Health Institute and Michigan Health Endowment Fund. And then there's also a resource, a lecture series by entitled 2023 Equity Upstream by the Mid-State Health Network that is also an exceptional resource that gives you more information about disparity and equity in the state. Next slide, please. And then there are also a series of anti-stigma videos that are very helpful and informative in helping you to situate or orient yourself to your own personal biases. Next slide, please. And E will share with you some of the work that the Injury Prevention Center is continuing to do around safe prescribing.
Thank you so much, Dr. Mitchell. So in conclusion, we at the Injury Prevention Center, in partnership with MDHHS, have created a toolkit, which is an online resource to promote prevention and safe prescribing. There are a lot of resources already available on that toolkit. We have rebranded it from the Opioid Prescribing Toolkit to a more general title, namely the Safer Prescribing Toolkit, because we have curated resources on safe prescribing of benzodiazepines and stimulants. The entire IPC website is being updated this summer and fall of 2024. And the toolkit will also be updated with some user-friendly search functions that hopefully will make it even better than it is right now. Next slide. As we conclude and get ready for some Q&A, I would like to remind everybody that August 31st is the day that we remember those we have lost to opiate and drug overdose. September is a month where we focus on recovery and supporting people who have substance use disorders and supporting them as they engage in their own recovery and reducing the harms of substance use. As we conclude the panel, the IPC, MDHHS would like to challenge each of you to access the resources that we've shared today and think about one resource that you would like to share with your organization, your team, and maybe act on, have that discussion, and let's see if we can move this work forward. So without further ado, we will have our Q&A. If I can ask our speakers to turn on their videos, and then Taylor has been monitoring the Q&A feature in our Zoom meeting, and she will share with us any questions that have been posed to date. We have gotten, we have already shared a lot of things that oh goodness, I'm sorry. I'm misunderstanding Taylor's message to me. So the question that she has for our panel is, all of us have shared a lot of things that we can do to help reduce disparities. If you can only focus on one thing right now, what do you think is the most important action? Dr. Mitchell, would you like to respond? So what is it, if you can only pick one thing, what is the thing that you would want our audience to focus on?
I think if I could pick one thing today, it would be to self-examine, picking one of the resources that enlighten you more about what implicit bias is, or implicit association is.
Wonderful. Taylor, do you have any other questions for our panelists? So the next question is, the Michigan SUD is very interesting. How often is it updated, and is there data on every county in Michigan? Gabrielle?
Yeah, so we update the MySUVI on a 2-year basis. So we have results for 2020 and recently released results for 2022. And it is available for every county in Michigan. And there's also a zip code version as well. So you can look at a more geographically granular level within communities how they stack up in terms of health disparities, health equity, and substance use disorder and overdose.
Thank you, Gabrielle. Let me see. Okay, there's one more question. So DEI efforts are being challenged across the country. Organizations may need to figure out how to address disparities in novel ways, whether it's through the language that they use or their actions. What are your suggestions for how we can do this? Dr. Asabigi, would you mind responding to this? And then maybe Karla as well?
Yes. Thank you for that question. It is a challenge, but there are other ways for us to look at, the resources available, making sure that we're intentional to include others, from vulnerable populations. I don't think that the laws and the rules and the changes would preclude individuals that really need services or have the need for those services. So I would say just being intentional, making sure that, anybody that you encounter that requires or needs services, that you ensure that they get the service that they need. I think that would take care of it, moving forward.
I would say that we have a personal responsibility to humanize the healthcare experience, and that we become aware of why DEI was in place in the first place, and that we make a personal commitment to be aware and to practice what we learn in ways that break down barriers for people as it relates to stigma and bias. And we model that for others and be intentional about increasing others' awareness, and each one teach one and proliferate throughout organizations. I think it's an and both and not an either or, but we absolutely have a personal responsibility.
Gabrielle, do you have any other thoughts on this issue?
Yeah, I think, my background is data. That's where I work and spend most of my time. But I think bringing data to the conversation and bringing concrete statistics that show that why these efforts are important and that disparities do truly exist. They're not just anecdotal, but we can point to concrete statistics that show the disparities that exist and why these efforts really matter.
Yeah, I think that is really critical, and the data is irrefutable. I think one other small point for people to consider is that when we think of disparities, we often limit it simply to race. Not that it's simple, but the conversations are often centered around race. There are many disparities in this country that receive less attention, but are also very important. For example, I'm an emergency physician. The disparities in access to emergency care for individuals in rural locations versus urban locations can be very stark. So having a larger view of what disparities might be, I think is also a really critical point. There's one more question that Taylor has shared with me. Does the toolkit you mentioned have resources on advancing equity in the care of patients with pain and SUD? Yes, it does. There are some resources already in place in the toolkit. And as a consequence of this conversation today and the fantastic conversations that we had with our panel leading up to today's seminar, we have collated and curated a whole series of resources that we'll be sharing in the toolkit that hopefully will make the work of will hopefully make this work just a tiny bit easier in that you won't have to search for resources in the same way. I think the other really wonderful thing about having a panel like this is our team at the Injury Prevention Center was exposed to resources and data that we actually did not know about. And Dr. Mitchell was incredibly helpful in sharing not only the work that she's done herself, but also some resources that we did not have access to just like by doing a Google search. So we will be sharing those with you in the near future. One moment. There is one more question. How are resources tested and accessible for those with disabilities, more specifically physical disabilities? Do toolkits and resources have data for helping those with disabilities access the resources? Does anybody have any thoughts on that? So if somebody has a physical disability, are there some resources? I can say for the toolkit, there are visual resources, there are text resources. I don't know that if someone is visually impaired, we don't have a mechanism, for example, for an audio search. But does anybody else have any thoughts? Gabrielle, do you know if MDHHS has any kind of enhanced accessibility tools on their website?
That is a good question. We have a lot of, I guess, like regulations on the tools we publish, trying to make them accessible. But I know there's more work we can do at the department, and I'm happy to ask around and explore if there are any more resources we could point people to.
Yeah, I think unfortunately, a lot of the publicly available resources are very much geared to people who are able to read. I will tell you that there are some wonderful resources, particularly focused on youth, where literacy level is taken into account. There are also a lot of wonderful resources through the CDC, the NIH, and SAMHSA in multiple languages. And so if, not that, not speaking English is a disability, but if you have a patient, for example, who's primarily Spanish speaking, there are some wonderful videos and resources in Spanish, in Arabic. I saw some in Portuguese, in Vietnamese. So those resources are available as well to kind of be more equitable in information sharing.
I would also add that the PIHPs may also have resources. They are also responsible for disability services. But those resources may vary depending on the PIHP. So I would encourage, the person asking to also, and the audience to check the PIHP in their region to see if they don't have, they have those services. If they don't, then we need to advocate for them to have those services available. They are responsible for intellectual and developmental disabilities too.
Yeah, that was a fantastic question. I think it's going to certainly make me think and make the IPC team consider how we're making our resources as accessible as possible. And like Dr. Asabigi said, reach out to your local PIHP and find out what they are doing to make sure that accessibility is promoted. Taylor, do we have any last questions? We're just about at time. All right, Taylor just indicated that that is everything. So with that, I would like to thank our audience for joining us today. I would like to thank our panelists for a incredibly informative, absolutely fantastic presentation. I know that my team learned a lot, and I imagine that everybody in the audience learned a lot as well. Just a quick reminder to please fill out the evaluation when you get it in your email box. And please, there is like an open answer box. Let us know if there are topics that you want to hear more about. If you want a follow-up presentation with more information about resources in Michigan, anything at all, we are very open to considering more topics and more seminars, and MDHHS is very supportive as well. So with that, I wish you all a beautiful day, and thank you again for joining us.